Welcome to The Cut, a series where I'm talking to experts about how small changes can have a big impact on patient outcomes after surgery. Hi Pam, thanks for joining us today on this episode. I'm really excited to have you here with me and tell me about some of your experiences in the world of acute wound management. And I was just thinking, if I wanted to ask anyone around acute wounds, particularly from a nursing perspective, you're my go-to. Tell me in your experience, what are some of the major challenges that you've faced in acute wound management, particularly from sort of being in the tertiary or the acute care setting on the wards for quite a number of years. So tell me some stories, Pam.
Thank you, Kylie. Look, I've worked in a tertiary hospital and had a wound, initially a clinical consultancy role and then nurse practitioner role. We know that surgical wounds and acute wounds make up about 50% of all wounds in our hospitals.
That's a lot.
Yeah, so it is a phenomenal amount that we deal with, and predominantly, we're looking at surgical wounds, incisions, drain sites, those kinds of things. So I think for me, wound care, I enjoy Wound Care Challenge, but we also have to look at how we best manage that in a consistent manner, using our best practice principles, understanding how wounds heal, how we can optimise their healing, and how we can look at putting the appropriate clinical guidelines in place to assist people in their decision making. And let's face it, in wound care, there's so many choices to make. So
it's
many
like
different ways of doing things. It is. So it's getting back to the fundamentals and the principles, and I think it's about education. And also, if you're introducing something new, then what's the benefit? How are we going to put that into place? How are we going to implement it? There's many things around implementation that are quite interesting. But certainly, I've gone from simple incisions to large dehisced abdominal wounds, laparostomies, the intensive care scenario.
Yeah.
As well as working in plastics and orthopaedics and seeing the trauma side of things prior to that. But the human body is an amazing thing. And I think in surgical wound care, you can certainly get a lot of satisfaction just seeing how they evolve and knowing what to expect in that wound healing journey.
It's interesting you mentioned implementation. It's one of these key magical catchphrases or catchwords at the moment, but let's put some meat on the bone with this one, because you're working in a large tertiary facility and you've come across something new and wonderful, and we've seen the evidence. How do you take that to your clinical practice and make the case for we really should be doing this, not that anymore? Tell me, have you experienced something like that?
Well, certainly, because as wound care's evolved with new technologies, that has certainly been the case. And a classic example would be the use of negative pressure wound therapy. And sometimes it's driven medically, but requires nursing support, and sometimes it's nursing-led, depending on the technology. I think it's always about having a long-term plan, because some of the principles of implementation science is you have to allow a year or more for change to occur. So we've got to recognise the process of change. And certainly it's about, start small, get your local champions and work from there. And certainly in my experience, it's the local champions. If you've got a good trust and rapport, they trust you with your judgment. There's appropriate support put in place. There's the resources, to support the change, then it can be very effective. But you do have to have the long-term vision, I think, and you do have to have a clear plan about how you're going to start it and how you're going to step it out, and what's in it for them, the old WIFM, because how is this going to influence their practice? Is it going to be less onerous in terms of the number of dressings they might have to do? Does it mean from the hospital point of view that you can discharge earlier, so you've got shorter length of stays, because that's always important. So you've got to look at it from different perspectives, from a patient perspective, from a clinician perspective, and also from an organisational perspective. and look at those benefits. And certainly if it's something major and it's going to cost to buy equipment or, to hire equipment, then you do need to look at a business case and develop that, and then you can outline the benefits and the long-term plan. And the same thing with, pressure relieving equipment when that first happened, which is some time ago now. You just had to build slowly, but you could demonstrate the benefit. And in doing so, you need to be able to measure pre, post. That might be just simple audits. It doesn't always have to be full on, but certainly if you can look at the situation before and then measure the progress afterwards and demonstrate that in some objective manner, then that just, endorses it. Because, there are many things that they might do a trial for 3 months or 12 months, but...
Like an evaluation.
It is an evaluation, yes. So we have to, ensure that it's doing what it's meant to do if we're implementing a change.
Sounds like there's so many masters of that change. It's not just the hospital executive. It's not just what's happening on the ward. It's the patients. It's what's driving those dollars, what's driving the outcome. In terms of the patient, what do you think is key for that surgical wound healing? It's so multifactorial. What do you think are some of the really key things that we can focus on improving?
So I think there's sort of two aspects to that, because when you look at surgical wound healing, there's elective surgery and then there's emergency surgery. So with emergency surgery, we can't really control the factors prior. Whereas with elective surgery, you certainly can. You can look at optimising the patient's health. So, and depends on the amount of time available, but education is key. And now I think we're much more aware about interventions pre-op, so they don't need the interventions post-op, just haemoglobin iron infusions.
It's back to basics, isn't it?
Yeah, it is back to basic. Optimise their nutrition. If they smoke, advise them against smoking. Certainly in plastic surgery with major surgery, that was a big thing, to stop for 6 weeks prior. Look at their overall health and fitness, but particularly education about what to expect after, so that you can optimise their rehabilitation, if you like. It might not require formal rehabilitation, but it's just adjusting post-operatively to having a surgical wound, how they might be moving, what they should avoid doing if they want to do harm, and how we can support that wound, or how they can support that wound to heal. So certainly having that rapport and relationship with the patient is going to be important. And in this era, pre-admission's often done over the phone. Prior, so that changes, or online. Yeah, I think online's always better if you can, because you just get that personal interaction. You can read things a little better in terms of cues,
and it's engaging them quite early on in their surgical journey. That human connection is so important. They're coming in for a scary procedure. They're already quite concerned, or maybe even worried.
Yeah.
It's nice to have that point of contact with that patient, and follow them all the way through the journey, because that's what that surgical wound healing is all about, that pre-surgery optimisation, what's happening in theatre, and that post-operative phase.
Yes.
When, big smile, it's a bit of a, do you think it's a bit of a vacuum in some cases? Would they kind of, once they're out of the acute care setting, unless there's a post-discharge surveillance program that's specifically designed to follow patients up and monitor them all the way through, if anything happens, they go to their GP.
The model has certainly changed. And again, the outpatient follow-up has changed because of changing environments, and managing the numbers of people that go through our health system. Yeah. So, and I'm not sure if the general practice scenario is always prepared for that. And having also now worked in community, I think community sometimes fills a gap. However, I still think there are opportunities certainly for more support post-surgery. And I suspect, I can't validate this, but I suspect there's a little bit of difference between the private sector surgical management and the public sector surgical management, just based on resources, different agendas from that point of view. Certainly with major surgeries, I think there probably is, good follow-up and good tracking. But with minor surgeries, I think there's just an expectation the client, the patient will get on with it and they'll be okay.
They'll
if there's
be
a
all
problem.
right.
Yeah.
Or they go see their GP or go to the pharmacist and ask, what do I put on this? But not in all cases, as we know.
No. I mean, there is post-acute care options there.
Absolutely.
Yeah.
And there's some great post-discharge surveillance programs implemented here locally, of course, in Western Australia, around the country, and also globally as well. So there's a lot of people working in this space doing some really exciting things.
Yeah.
So tell me, to a young nurse who's watching the show, some tips and hints for implementing change and following that change through in clinical practice. Some pearls of wisdom from Pam.
Implementing change, look, I think it's to a degree you have to be quite passionate about and quite clear about what this change is for, who's affected by it, so who's the target audience that you're aiming to influence, and thinking about how that affects them and how you can give them some ownership and control over the situation, getting them involved in the process so they have that ownership and personal sort of contribution to that change process. So definitely it's about getting those champions again, people on your side. So that may be about relationship building, because as you know, not everything is just about a piece of paper and words. It's about people. And so you have to understand people and what's going to be the trigger points for them. But you do have to look at the long-term picture of what is this change and why are we doing it? What is it going to achieve? How are we going to, ensure that it's actually been successful? But also, what lessons do we learn? And when you are starting out, certainly with things that I've discovered, you have to understand the enablers and barriers. So what identify early in the piece what might be the barriers from all of those different perspectives, whether it's infrastructure or whether it's people or whether it's education or other resources.
Funding.
And what are the enablers? So what are the things that are going to really encourage that change? So it's getting a good feel for what might block or what might enhance that change and the benefit of that change, and having those local champions, those link people, the supporters. But certainly if you can engage, depending on what level you are in the organisation, who's above you, who's behind you, and how can they support you. Certainly if you're looking at management, you've got to get through management. Who's going to do that? Who's the person that you're going to go to that's going to support you and is going to, promote that at that level, that organisational level, if decisions have to be made.
It's such a team approach, and it's multidisciplinary as well, which is really, when you think about it, how wound care is delivered.
Yes, absolutely.
It's just about building your team.
Yeah.
And making sure everybody's got a role and we all know what we're doing and implementing that and driving that change through.
Yeah.
But it sounds as though also is that you've got to have that fire in the belly and you've got to have the passion to be able to see it through as well.
Absolutely.
Great tips. Really great tips.
You do have to be passionate and you have to believe in it. And you've got to have patience, persistence, perseverance, all of those things to follow it through, and obviously you need to have a plan.
Wonderful. Some great tips there. And thank you so much for sharing your story and experience. It's just been a delight to hear what you've done in your clinical practice to drive that change through and improve patient outcomes. And thank you.
Thank you,
Thanks
Kylie.
for joining me, Pam.
It's a pleasure.